Okay, let's get started. Thank you for joining us today. My name is Lisa Johnson, and on behalf of Everbridge, we're excited to present this webinar, Disrupting Healthcare, How Secure Messaging and Telemedicine Are Changing Patient Care. Our panelists will have a discussion on a number of topics, from current day uses of telemedicine to the big news of the Joint Commission lifting its ban on texting orders. After the presentation, we will have a 15-minute Q&A session with our speakers. We're going to start by going over the agenda. We're going to do some logistics and some housekeeping, introduce the panel, do an overview of telemedicine and HIPAA-Bridge. Then we have a great study from the Mayo Clinic. It was a pilot study that was just announced a couple weeks ago at the ATA conference. We'll go over some commonly asked questions about telemedicine, and then we'll discuss the Joint Commission decision on texting orders. There'll be just a little bit of panel discussion to kind of wrap up our conversation, and then we'll have an audience Q&A. Before we get into our discussion, let's introduce our panelists. Dr. Ranya Habash. Dr. Habash is a founder of Eye Physicians of Florida and sits on the Executive Council and Surgical Management Committees for West Boca Medical Center. She was named to the Elite America's Top Doctors list for 2015, which represents the top 1% of physicians in the nation. She also is active in the Florida Society of Ophthalmology. Keith Algozzine is co-founder and CEO of Upstate Concierge Medicine and Management. Before creating Upstate, he was the chief PA of emergency medicine for St. Mary's Hospital in Troy, New York, as well as part of the National ER Startup Management Team for Pegasus Emergency Medicine. He is a co-founding member and director of patient services for SwiftMD, a nationwide telemedicine company. Dr. Alex Grilli is an otolaryngologist and joined Mass Eye and Ear in 2002. His clinical interests include pediatric ENT, endoscopic sinus surgery, and obstructive sleep apnea. He is also an instructor of otology and laryngology at Harvard Medical School. Dr. Rahul Shah serves as Vice President, Chief Quality and Safety Office at Children's National Health System. He oversees patient safety, quality improvement, accreditation and licensure, patient care policies, and collaborates regularly with medical staff to improve the outcomes of care. As an ENT, he focuses on pediatric voice disorders, resource utilization and outcomes, and medical errors. Okay, so let's start our full discussion with a brief overview of telemedicine. Dr. Habash, please take it away.
Thank you, Lisa. Everyone, welcome to the webinar today. We're going to have some fun and talk about a lot of use cases for secure texting and telemedicine. We'll start with a quick, brief overview of telemedicine. I know many of you think this is kind of a new concept, but it's really not, and this slide kind of shows that. Actually, I'll start by saying that the very earliest form of telemedicine was actually smoke signals, so that tribes could send a message to a neighboring tribe as to whether or not there was an outbreak of disease. So the whole concept, I mean, has been around forever. In this slide, you can see that there's a radio advertisement advertising a doctor visit by picture, and that appeared in 1924. In the medical literature, the first cases were published in 1950, and it goes on and on from there. You know, ship-to-shore transmissions for EKGs and X-rays date back to the 1965s. In the 1960s, and prisons have actually been the biggest utilizers of telemedicine for many, many years, saving taxpayer dollars and keeping everyone healthy. So today, telemedicine incorporates platforms conveying voice, images, video, dictation services, and diagnostics, and that's really how it's changed throughout time. Keith, do you have anything else to add here?
No, actually, I learned something new as well. Smoke signals, very good.
Yeah, that one's my favorite. Okay, well then we'll jump to the next slide. So what are the best use cases for telemedicine? Alex, Rahul, do you guys want to get this?
Yeah, I think this is Alex. You know, one of the real things, the real advantages obviously of telemedicine is, as you mentioned, Ranya, you know, in prisons or other areas where there is difficulty recruiting physicians to work, also where there are geographical barriers, low population density, if you're talking about specialists or or someone who has a unique skill set, it's very difficult to get them physically there, and telemedicine can provide that, that link between, kind of eliminating the physical barrier. It's very useful in mental health, for checkups, wellness checks, and as well as just chronic conditions, monitoring conditions where a lot can be done without actually physically being present.
And I would add to that, I'm sure Keith would second this. This is Rahul Shah from Washington, D.C. In academic medical centers, we're finding real value in telemedicine. We have patients who will come to us, as you know, Ranya, from many hours away, and sometimes for a post-op visit or for a routine follow-up appointment, it's much more convenient for the family. It drives patient experience, and it helps us at the main campus to provide telemedicine. And I'm sure Keith has experienced that as well as yourself, Ranya.
Yes, absolutely. Being at the University of Miami, we get transfers all the time from out of the country and out of the state. We're a huge catchment population, and oftentimes, most times actually, we triage things over the phone. We don't really know what's going on, and so we're talking to the doctor on the other end, and everything's being described via telephone. Well, imagine if you do a video triage instead. You're making those transfers much more. Hello?
We'll just keep going, Ranya. You're still there.
Okay, all right, great. So imagine if you can talk to the doctor on the other end and do a transfer and make sure that patients who need to be transferred are, and patients who don't really need to be transferred are also saved that expense and those problems involved. So we're finding with patient transfers and consults that the telemedicine via video, HIPAA-compliant video, is very, very useful, both for patient care and for the bottom line for the hospital.
Hey, Ranya,
that's the next slide.
I just want to jump in. Yeah, I just want to jump in real quick there. The other thing, obviously, you guys are right on hitting the sort of barriers that telemedicine can break down at a distance. And we often hear all those things from the rural areas and getting patients care who wouldn't ordinarily need it or wouldn't ordinarily be able to get it. But the other thing that I think is really powerful that some people forget is when you're trying to deliver the most efficient care, you could have a hospital right across the street and urgent care a mile down the road, and the right care, the most appropriate care, might be a simple telemedicine visit. If you're trying to reduce costs, just because you can get somewhere, telemedicine still might be the right solution. And so we like to try to think of things as, care should be the right place at the right time. And that may be at a distance, but it may be that you have the ability to get right to the hospital or right to the clinic, but it may be the more efficient approach.
Exactly, yeah, and that's a very good point because we talk about the use cases, and we could spend all day on this one slide because the use cases are infinite. It's kind of like asking, what is the use case for light? There are a million different things, and we're giving everyone a tool here, and people are going to use it in different ways. So let's talk about this tool. We'll do a quick brief overview of HIPAA Bridge so you guys know exactly what we're talking about. So it sounds fancy and complicated, and telemedicine sounds like a huge barrier to your institution, but it's not, because the concept is very simple. It's just iMessage and FaceTime, but it's HIPAA compliant, period. So you can text, you can send voice messages, you can do video calls just like FaceTime-like video, and you can dictate. And this is all done on a HIPAA compliant platform. So everything you do within the app is HIPAA compliant, and you're protected. So you're protecting your institution against fines up to $1.5 million, and you're protecting yourself from fines up to $50,000 per text or per incident. And I know that in my hospitals, texting non-compliantly is that runs rampant. I'm sure the same happens in Mass Eye and Ear and Washington, D.C., and everywhere, because it's not that we're just trying to break the rules, it's because, this is all in the interest of good patient care. So how can we still deliver good patient care and be HIPAA compliant? This is how. It's HIPAA Bridge. So the next slide, this is a very obvious thing, but we'll go through the steps anyway. So Dr. Grilli, Dr. Shah, do you guys want to go through this? Why would you use HIPAA Bridge rather than do things the old way?
Absolutely. Alex, we are both so passionate, one of us. Go ahead, and then the other can fill in the gaps, right? As clinicians, we jump all over them. Go ahead, buddy.
Yeah, I mean, I'd like to just go down to the bottom of the slide because I think the stroke diagnosis really kind of illustrates the advantages of the HIPAA bridge the best. They're all good examples, but you know, in stroke now, the kind of catchphrase has become "time is brain." So when someone's having a stroke, it's a very acute situation, and what needs to be done is a care team needs to be organized. And if you think about traditionally how this is done, whether it's done with phone calls, pages, you know, conversations from one caregiver to another, it takes a long time to get all that organized, and during this time the patient's having an active stroke and every minute counts. Whereas with HIPAA bridge, specialists, nurses, all the care team members are simply, you know, a click or you know, a secure message away, and just coordinating that care team makes it so much more efficient. It's so much faster. I mean, if you look at the average time on the slide, 3 minutes versus, you know, 10 times, 25 to 30 minutes. So I think that's the real advantage, is just coordination of a care team in a very acute situation.
Alex, I really like that, and you build on it. This is a great slide. If you look on the right-hand side column, all of these case studies or use studies have real data behind them. And we know anecdotally in the office as a specialist, when I'm trying to communicate with a primary doctor, it's really hard to reach them. I call their office. If I know their back line, I'm on hold for maybe 5-10 minutes. I interrupt them with the patient, all to communicate only something that took 30 seconds. And that's where HIPAA bridge enters. It's convenient, it's fast, it's secure, and gives us the platform to do asynchronous communication, which is what we need most of the time.
Exactly. You know, we're as you know, clinicians, physicians, physician assistants, nurse practitioners, everyone's busy, everyone's dealing with their own thing, dealing with their own patients, and you know, to leave a situation that you're in and to go answer a phone call, miss a page, you know, it just takes so much time. It's so inefficient. Whereas with the asynchronous communication, as you mentioned with HIPAA bridge, I get a message, I do what I'm doing, I reply to it. It's the flow of patient care is not interrupted. It's a much better workflow, much more efficient.
Exactly. I mean, we're all getting, you know, texts. I get texts from my vet about my dog. You know, we get texts from the airlines about our flights. You know, healthcare is kind of like the last frontier here, where, you know, people really haven't caught on, and this seems like such a new concept, but it's used so widely in our everyday lives, and we just have to apply it to healthcare now.
And Raina, what you said is interesting. We were intimidated because there wasn't a HIPAA-secure platform. And then we'd say, well, it's not efficient. Well, you can't do group messaging. It's almost like all of the problems have been fixed by the HIPAA bridge. You know, as you said, the barriers have been provided in the solution.
Exactly. And yes, you can do group messages. In fact, that's probably one thing I should have outlined in the slide with the functions. But you know, one of the biggest problems I face when I go in to see a patient in the hospital is I'm an ophthalmologist, so I'm one of the last people consulted on a case, and I never know what's going on. I have to like go through the chart and look through everything, you know, which takes a long time. And then you can't read anyone's writing, and even though we have EMR systems, it still is a very inefficient system. With HIPAA bridge, if someone brings me into the group chat, which is centered around a patient, I can just, as soon as I enter the group, I see the entire preceding conversation. So I know all these little nuances of the case, and I'm caught up very, very quickly and can start contributing right then and there. So this is a good segue to our Mayo Clinic, the stroke team case study that we just talked about. So I'll tell you a quick story about, you know, how this even got started. I was reading something online, and it was saying, it was a little, you know, fun fact about how 85% of patients who call 911 actually never get admitted to the hospital. And think about that. So it's 85% of patients who call the ambulance are never admitted, which means that they really didn't need that ambulance. And who's paying for that ambulance? It's taxpayers. And it's taking away resources from patients who really need the transport and the facilities there. So these patients are patients who just needed help getting off, you know, the toilet, or needed help with their medication because they couldn't figure out which pill was next. You know, these are things that could have been triaged and dealt with via video call. And the flip side is true too. You know, like I was saying, the patients who really need these resources are not getting them. And that's the stroke patients. So like Dr. Shah was saying, you know, time is brain. For every minute that a stroke patient isn't getting intervention, they're losing 1.8 million brain cells. So any minute you can shave off of that door to needle time is going to benefit the patient tremendously, and ultimately the health system as well. So what I thought was, well, let me take it to the, one of the top institutions in the country, Mayo Clinic, and see if their stroke team is interested in doing some sort of a pilot study with me. And they were, and it was a very, very simple study. All we did was put an iPad mini with HIPAA bridge on it on the ambulance and see if the neurologist at Mayo Clinic could triage a stroke patient while they were in transit. The triage is called the NIH stroke scale. Can it be performed? It was a feasibility study. Can it or can it not be performed? Well, it turns out it can, and it can be performed very quickly and easily as well. So we were able to perform this stroke scale on every single patient. The time saved on the door-to-needle time was 7.45 minutes. Now, think about that number and multiply it by 1.8 million brain cells. And that's the difference between a patient walking out of the hospital and being wheeled out, and not recognizing their family anymore and not being able to speak or walk. That's the difference here. This is very real data that ended up translating into lives saved and brain cells saved. We also, as a side effect, decreased the hospital length of stay and the complications while the patients were in the hospital. In one case, we decreased the length of stay by 13 days for a patient. Incidentally, that patient was uninsured, and imagine the cost to the health system and the patient there. The cost savings for the actual setup, putting the iPad mini with HIPAA bridge on it, was $285 versus the $1.5 million robotic system that Mayo Clinic also had, which incidentally sat in a closet collecting dust somewhere because no one ever used it because it was so cumbersome. And that's another very big, value there. I mean, it shows that not only was better care delivered, but we also saved a whole bunch of money. The other little statistic I'll give you is that while we saved 7.45 minutes off the door-to-needle time, using the robot, we did another little study at the same time. Using the robot added 8 minutes to the door-to-needle time. It added time to that diagnostic or to that intervention time. And the reason was because the robot was so cumbersome to use that it added time to the whole process. So we saved lives and brain cells, and yes, I had to use this thing. It's priceless.
Raina,
so
this is Rahul. That's an excellent study,
yeah.
Raina. And I really like how you drove down the concept of value. Medical centers, healthcare institutions, everywhere in healthcare is looking at value. And value is defined as quality over cost. And what's awesome about the study you just presented, you improved quality by an order of magnitude, and you reduced cost by almost 3 orders of magnitude. A tremendous value from the HIPAA bridge in this situation. So nice work, Raina. Nice study.
Yeah, it was excellent. In fact, it got published in the Journal of Telemedicine and Telestroke recently and was presented at the American Telemedicine Association's National Convention just 2 weeks ago by Mayo Clinic themselves. So we can go on to the next slide. I have to say it, though. I'm so sorry. This is my favorite line. HIPAA bridge is such a no-brainer. I mean, we could talk all day about this, but again, I'll use that the bad pun. It is a no-brainer. Okay, so moving from the inpatient setting and emergency setting to how do you roll this out to your patients? So I'll tell you, we want to hear from Keith because he's really the major user of this technology for outpatient settings. Keith, would you like to take this?
Sure, Ranya. So, yeah, I mean, I don't want to, totally underscore what we do with providers too, because I think what you guys are talking about through provider communication is absolutely critical, and we use HIPAA bridge for that as well. But to us, that was sort of the low-hanging easy fruit because, like you said, we've all been doing this, right or wrong for some time anyway, and that just, HIPAA bridge just allows us now to do it in a secure, really friendly manner. So we love that component of it. But how we roll it out to patients was really the exciting part for us because we are just quick background, we're a full turnkey telemedicine solution. So we're both the practice management, we use technology like HIPAA bridge, but really we're the providers of the telemedicine care is sort of our biggest playing a game here in space. So when we roll it out to patients, we just thought to ourselves, okay, we want to provide this cost-efficient, convenient care for our patients. And as we started, years ago with telemedicine, we quickly learned that video alone, while provided a great, medium to interact with patients, it actually wasn't the preferred method for both patients and our providers. And if you want to sort of change care, you have to sort of at least jump on board with the drive for consumerism. And you have to understand what patients want to use and want to do, and then you have to strike a balance for how the providers will both use it and then make sure they're comfortable in making appropriate diagnosis. So in our practice, we start most of our consults with a simple phone call. And some things can be solved with a simple phone call. But obviously, many of these interactions between provider and patient, we need to take the next step, and that includes picture and video. And what we find is, of an order of magnitude of, almost tenfold, patients really, really love the ability to text both, asynchronous, just communication in words, and then the pictures. So the combination for us of having a phone conversation followed with a picture, and I'll just give an simple example of a rash. We talk to a patient and decide that, this sounds like it's shingles, for example. But obviously the provider needs to confirm that diagnosis. When you give both the patient and the provider an option of what the next step is, they choose far and away, both the provider and the patient say, oh, we've got this history fully worked out. Can I just send you a quick picture and a quick text? And patients love it. Our providers love it. And the patient part is pretty easy, right? Everybody understands, that, a patient would love to send a picture. We do that in our everyday life. Why wouldn't they love to do it in a medical practice? But the part that's interesting why the providers like it is if you have a picture, for example, in real time, you take a quick look at that rash, for example, on somebody's arm, and, it's gone in a flash. And maybe, you didn't see it as well as you thought, or you wanted to get a second opinion. With HIPAA-Bridge, what we're able to do is we're able to look at that picture, we're able to, blow it up, we're able to look even closer at it, we're able to send it to 3 of our colleagues and say, hey, what do you think? Do you think this is really shingles? So it's really a powerful tool for us, especially on the texting, the picture platform.
That's great, Keith. Thank you so much. And just to add a second step to that, as soon as you end up doing a real-time video call from the HIPAA-Bridge app, boom, that's a reimbursable visit. And that's really the difference. So it's not just secure texting and sending pictures here we're talking about also doing a consult while the patient, with the patient via real-time video, which is a reimbursable visit from most payers.
Correct.
Okay, we'll go to the next slide. Okay, so what are some common hiccups when working with a patient new to telemedicine? I can actually start this, and then Keith, maybe you can finish this. So, so I am a practicing ophthalmologist in private practice and academics, but my private practice is in Boca Raton. My patient population is like 90 years old. And I thought that there's no way in the world my patients would ever adopt telemedicine. But boy, I was wrong, because these patients come in with their smartphones and with their tablets and iPads, and they sit there and video chat or do FaceTime calls with their grandkids or with their, their Mahjong teams or whatever, they have going on. And they all know how to use an iPad. So they know how to download apps. They sit there in my waiting room, play Candy Crush while they're waiting on me, and they easily do FaceTime calls and text. So if my patient population can get this, anybody can. And so I don't really have too many hiccups, actually. I mean, it's very simple. What I do in my practice is I have something in their patient registration, and it says, hey, your doctor is now offering telemedicine visits. Go to the App Store, download HIPAA-Bridge app. Done. And within 2 minutes, literally just like Candy Crush, they're up and running and they're able to HIPAA chat with my office. So Keith, would you like to take it from here?
Sure. Yeah. I mean, I'll ditto those sentiments. I'll tell you, the actual app itself, and one of the things that we like best about HIPAA-Bridge is it really mimics what people do in their everyday life through texting, through video conferencing, FaceTimes, and things like that. It's incredibly user-friendly. We essentially have zero hiccups with it as far as the HIPAA-Bridge platform. The only hiccup that I'll share is just more, if anyone's looking for workflow solutions, is, it's tough to get people to do things ahead of time. So just like, I'm sure, Alex and Rahul, they live this world too. I'll use patient portals as the example. You send them the information over and over and over, and such a low percentage of the people sort of adopt and sign into their patient portal. Well, we do the same thing with our patients. Please download the app, download the app, download the app. And they're invariably, it's a large percentage of people until they actually need us and they're sick, then they reach out to us and then they engage with us. So our little hiccup is, man, how do we get more people to download the app ahead of time? Because it just adds a little time for us to say, okay, now download the app. And then, but once they download the app, I mean, it's a home run.
Yeah, you're totally right about that. And what you said was exactly true. They really won't do it a lot of times until they need you. So in my practice, if they wake up with, a bloody eye, a subconjunctival hemorrhage, and they're freaking out, they will download the app and then call my office. And likewise, when I'm setting up a quick follow-up visit and I give them the option, hey, you have, pink eye or conjunctivitis, and I need to see you in a week, but we can do a telemedicine visit for that. And you can stay at work or you can stay at home with the kids. You don't have to get a sitter and come into my office and wait for an hour for a quick conjunctivitis follow-up visit. Would you like to do that? And they think I'm kidding because they say, who wouldn't want to do that? That sounds awesome. And so what we do is upon the checkout, my girls at the front desk will give them the flyer and they'll download the app. And then when we call to confirm them the day before, like we do any normal patient, we send them a confirmatory text via HIPAA-Bridge and just make sure they're up and running. So that's one way that we make sure that we've closed that loop and make sure everyone's up and running before their next visit. It's just a confirmation, just like you do with any other patient the day before their visit.
Yeah, actually, I'll add one other thing I forgot to add, just because it reminded me when Rahul or Alex, I can't remember which one, was mentioning the interruption that you provide with doctors when you need a consult and you're trying to call their primary care doctor and then you pull them out of the room and all those issues. It's amazing. Those things are actually tremendously transferable to the patient population, I'll tell you, because, for example, what we also use it for, HIPAA-Bridge, is for some of our follow-up. So just like doctors, our patients are busy. So if our doctor wants to follow up with a patient, and I'll just use your conjunctivitis example, and say, hey, we want to see if your conjunctivitis is getting better. If I call them at, what time is it, 1:30, they might be in a meeting or, say, a webinar, and they're not going to answer their phone. But if I send them an asynchronous message that says, hey, just checking in, wanted to see how your conjunctivitis is doing, well then, I mean, listen, we all know how that works. As soon as that meeting's over, everyone's grabbing their phone, turning it off silence and seeing what happened, and they see that the doctor reached out to them and wants to know how their conjunctivitis was. They can, A, they'll actually get that, so it won't be a lost patient to follow up that you won't know what happened, and B, they'll either respond back or call back or whatever is necessary. So that's a really powerful tool that HIPAA-Bridge brings.
Agreed. Okay, we'll go to the next slide. Okay, how does billing work for telemedicine? This is a very short slide. It's a short answer here. You bill it exactly the way you would a normal office visit. And so what I do in the practice, for instance, is I bill the same CPT code I was going to bill, like 92012, something like that, 99212. And I just put a GT modifier on the end of it. That tells the insurance company that that was an e-visit. And an e-visit is defined as a real-time video visit on a HIPAA-compliant platform, and that's what HIPAA-Bridge is. It's basically a FaceTime-like video visit that's HIPAA-compliant. So as long as it's a real-time video like that, you can bill for a consult, or you can bill for whatever CPT code you normally would bill for, and get reimbursed 100% of that code. So the same as an office visit or same as an in-person visit. This works for new patients, consults, and follow-up patients as well. And every payer is paying except for Medicare. Medicare pays for patients in remote areas. It has to be a very specific rural location. But other than that, Medicaid and all the private payers pay in almost every state. You know, every state is a little bit different, but I know in Florida, they pay for everything that's non-Medicare.
Yeah, just to expand that a little bit, sorry, Ranya, it's Alex. Just to expand that a little bit, Medicare, you're right, remote areas, it's covered. Also, people who have Medicare Advantage plans can take get the full benefit of telehealth. And also regarding at the state level and private insurers, right now 29 states have mandated that private carriers pay for telemedicine visits as well as the District of Columbia, and that's expanding.
Exactly, and there's tons of legislation out there now. It won't be long before Medicare and the rest of the states are up and running too.
Yeah, it's the wave of the future.
Okay, Alex and Rahul, you guys seem like you know a lot about this slide. How do I coordinate with insurance providers for telemedicine? Would you guys like to field this?
So I think this is Rahul Shah. It goes back, Ranya, to your other slide where it's a short point. Work with the insurers to make sure you use the designated codes, make sure your documentation supports that. States have nuances, and it's not worth the time for us or Everbridge to expound upon that in 50 states and then municipalities, provinces, etc. They all have slightly nuanced rules on telemedicine, but it is, as Raina said, starting to get reimbursed. But you must work with the providers, get the specific code, and ensure documentation. That's pretty much how we do normal coding, but you just have to be very cognizant of what you're doing. And also, I would follow up from accounts payable to make sure that it's really hitting once you submit that bill. Alex, anything more to add?
I think that's pretty much the gist of it. I mean, it is very, right now it's still, so varied from state to state and from payer to payer. I think you made the main points.
Yeah, and there's really only one code. It's just the GT modifier. So just like if you were doing a procedure, you need a modifier. This is, telling your insurer that you did an e-visit. And you're exactly right. You should just document the way you normally would in your EMR system or otherwise. Okay, we'll go to the next slide.
Yeah, that's actually
so how do I track? Yeah, how do I track telemedicine visits in my EHR? Go ahead.
Yeah, exactly like you said. One option is to document it just like you would any other visit. With the subjective, objective, your assessment and plan, and basically document what took place during the telehealth visit. But increasingly, now with obviously everyone has broadband connections, and with the increasing robustness of secure portals and secure servers, we're getting to the point where we can actually record the conference and include that as part of the medical record. That has a lot of other ramifications to it, both medical, legal, and just cost. But I do think that in time, that's really going to become, increasingly prevalent.
Yeah, I'd agree. And for right now, you kind of cherry pick what you want to be in the medical record, which I think is really the way it should be, and the way it is done in a normal face-to-face visit as well. Exactly.
It's just when you see the technology coming, eventually things may change where the whole conference can be put into the EHR if desired.
Yeah, exactly. So yeah, it's important to have that capability and let the health system choose how they want to do that.
Agree.
So we'll go to the next slide. Okay, how does malpractice and telemedicine work? Another very easy point to make, I have yet to come across a malpractice insurance that doesn't cover telemedicine. This is usually a covered service. There's no extra charge. I checked my own malpractice, which is national carrier, and there's no extra charge for my practice of telemedicine. It's covered as a regular service via pretty much any malpractice carrier. Do you guys have any other opinions on this, or have you seen anything different?
Yeah,
I agree
with
you
you 100%.
Alex, Keith, Ranya, I think it also goes back to being a good provider, documenting. There's certain aspects of a claim to be malpractice, and it's not just telemedicine or speaking on the phone. There's certain things that have to happen. Keith, you probably have the most experience, if there is any unfortunate, from malpractice, but I'm thinking on the top of my head, there's not a lot of cases that come to mind. Do you know, Keith, of any?
Well, yes, I do. I mean, I can tell you we've done extensive research on this, and there are most of the malpractice carriers will include telemedicine. There are some that still won't, so you should definitely check with your carrier. If they're not covered, though, I can tell you it's easy to find sort of a supplemental policy that will cover telemedicine. So it's really wouldn't be a hard stop anyway. But it varies state by state too, believe it or not, just like everything else, these malpractice carriers look at the state laws and legislation and what you can do and what you can cover. But I mean, the big picture here is that, and it's early, but the malpractice, both costs and sort of the system is phenomenal right now. It really, the rates are great because really telemedicine, to this point, there hasn't been a lot of malpractice suits that have come forth over the past really 10 years that it's exploded, which, is great because it keeps the rates down and it sort of, validates the fact that these carriers can continue to cover it. So I think it's been a good experience, but you definitely need to check with your malpractice carrier and make sure.
Thank you, Keith. Okay, we'll go to the next slide. Okay, so I want Dr. Grilli and Dr. Shah to spend a little more time on this. There was a big decision from the Joint Commission recently. It reversed a ban on texting orders. So doctors can now text orders to the nurses on the floor in the hospital. So guys, will you like to elaborate on this, please?
Alex,
yeah, sure.
I'm going to speak first because I just beat you to it. I'm sure both of us were so excited by this, right? We chatted with Ranya and Everbridge when it first came out. It's actually so profound. I'm going to insult all of us and just read it for a second. Licensed independent practitioners or other practitioners may text orders as long as a secure texting messaging platform is used and the required components of an order are included. So it's short, but really interesting points. So the first one, LIP or other practitioners. That opens the door for Alex to text an order to me, perhaps as a respiratory therapist or as a social work, etc. Fascinating. Then the last couple words are also interesting. The required components of an order are included. So, we'd say respiratory therapy, please provide chest physical therapy on patient in room 703. That's what I would write on a normal order. That's what I'm going to do on texting. The middle part is also the most important, and here I would say enter HIPAA Bridge or Everbridge. A secure text messaging platform is used. Prior to this decision, the Joint Commission and HHS were leaving pretty significant fines when people were texting, which was happening all over the country, without a secure messaging platform. And now that they reversed the ban on texting orders, what we believe is going to happen is now they're not going to question that you're using the orders, but they're going to question that your platform has integrity. So this is the time to get the right platform that's HIPAA secure and has all the right auditing tools in place. Just because a platform tells you they're HIPAA secure, it's really far from what it is. And you don't want to put yourself at liability by using the wrong platform. Alex, I took the easy part because I talked about the decision. This is obviously something that's really going to transform healthcare. I'd love to hear your thoughts.
Yeah, and I think it all reflects back to what Ranya said in the beginning of the webinar. You know, medicine is now starting to catch up with the rest of the world with regards to communication. You know, text, you know, it really increases efficiency and accessibility. You know, if I'm doing something where I'm in my office or you know, in the hospital, and I have inpatient somewhere else in the hospital, or even at another hospital, and a nurse needs a simple order, she sends me a secure message, and I send a message back. It's so easy. Rather than paging me, waiting for me to call back, she's with another patient, and then I have to wait for her to get to the phone, and you know, just it's just the. I think it's really going to be a game changer as far as delivery of healthcare. It's really going to increase efficiency throughout the spectrum of healthcare. Just like text messaging has made communication more efficient for the rest of the world.
Exactly. Very, very well said, Dr. Grilli and Dr. Shah. Thank you so much for that. I'll add one final thing. So not only is it more convenient and more efficient for everyone involved, it's actually more accurate too, because I was reading a study recently about how verbal orders get confused a lot. And anytime you're dealing with a verbal order, there is always room for error in the dosing or the route or the number, you know, the administration of the medication. And when you text it, you have a read receipt and you have everything printed, and it's actually far more accurate than verbal.
It's a great point. And as we, some of the physician workforce ages and our memories aren't as good as they used to be. You know, sometimes it's good to, just like we write things down, it's very important and more accurate to have a written record rather than, you know, a verbal communication which can be misheard or misremembered or what have you.
Exactly.
Yeah, if I can just interject, this is Rahul again. I don't want the significance of this to go unnoticed. So let's take your workflow, Ranya. You're seeing patients in the office, probably 30, 40 patients a day. You have patients that you're consulting on, and if you can get an order or communicate with a provider or nurse in the morning instead of waiting till after your office is done at 6 at night, you've just sped up throughput. You've gotten that patient taken care of 8 hours earlier. They can go home sooner, and this goes all back to value in healthcare. You're providing higher quality, more efficient care at a lower cost. So this is where I think it gets really exciting for us in the workflow of our day. We're going to be able to manage patients when we're not in the building. And so this is where I think this is really profound and is going to help efficiency in the healthcare system.
Absolutely. Very, very well said. I think we can pretty much end on that note and take some questions. Do we have any more slides to get through here? Or we kind of talked about this, the Joint Commission platform requirements, secure sign-on, encrypted messaging, delivery and read receipts so that you know that someone got your message, a date and time stamp. Those are all standard things for authentication, which you would get with HIPAA Bridge. Customized message retention timeframes and a specified contact list for individuals authorized to receive and record orders. Dr. Grilli, Dr. Shah, would you guys like to add anything here?
No, I think as you said, this is all just authentication, and you know, if you're going to take the leap, which, you know, surprisingly Health and Human Services has done to embrace mobile technology, then, you know, you have to be sure that, you know, you have to know who's sending the order. You have to make sure that they're sending it to someone who's authorized to act upon the order, and you have to make sure that you know, the time and the date are correct. So, you know, this is a big leap in embracing technology, and I think that these are basically safeguards to ensure that there's no risk to patient safety or patient care.
Alex, I like what you said. If you are going to embrace this, then go back to what Ranya articulated on the prior slide. I don't know if you can go back to slide 19, Lisa, that would be great, showing us what you need to make sure that the platform has. And that's what really scares me, because people are going to say, oh, well, now we can just text. And indeed, that's not the case. And I can't imagine HHS is not going to be auditing and looking into this. So, you know, embrace it, but you've got to embrace it with the right platform.
Exactly. There's a lot of problems with standard text messaging. You know, authentication being the main one, and encryption, of course.
Great. Okay. I think this leaves us just enough time for some questions. What do you guys think about opening this up to some questions from our crowd here?
Okay, we've been gathering your questions. We do have a couple to start off with. The first one is, how do you handle a large influx of texts from patients once they recognize that reaching a care provider is much easier than planning an office visit? Great question.
So I've got my answer for this, but Keith, do you want to take this one since you guys get this all the time?
Yeah, sure. No, it's so I mean, I don't know how everyone deals with this because it's really it's a workflow issue for each individual practice. So for us, I mean, we're a 24/7, 365 telemedicine practice, so we always have someone on call and we have someone on backup, and we actually have somebody else, administrator, who can handle these texts. So it's, you know, I akin it to, it's really no different. And people ask us about telemedicine in general, sort of the direct-to-consumer model, which we have both for our healthcare organization partners as well as our own individual practice, is, you know, it's about load balancing and figuring out a method to make sure that, A, nothing's missed, and then to make sure that the right person gets the messages. So I personally say that that's a internal workflow issue, and it's one that's easily handled just like anything else. How do you handle when 20 people walk into your ER or into your urgent care? Really, all these things are transferable to what we already do in medicine. It's just using the technology and making sure you have the right workflows.
Exactly. So one of the ways that I do it, just and what you said was perfect. You know, everyone is going to have a different way of doing this. What I found works best in my office is if I initiate all the calls and texts. So I tell my patients that when they do have, you know, an issue and they need me or they need my office, what do they do normally? They call my office, and that's what I tell them to do again. And if we find, you know, that it's something amenable for an e-visit, then we'll set up, or we'll ask them to text us. But I don't want them I don't want to miss texts from my patients, and so that's how I like to handle it. And I think it puts a bottleneck there that makes it a little bit more manageable for my staff. But again, everyone will have a slightly different workflow.
Okay, let's move on to the next question. If the text could potentially stay on the device, how is that HIPAA compliant?
Anybody want to take this, or?
Yeah, Raina, this is Rahul. Why don't I start, okay, and then maybe our Everbridge colleagues can provide some further insight. So the platform that you're using has certain features, and I'm trying not to get technical, that's why I'm hesitating. You know, within there it has a security. The server that they use is secure. So it's not staying on the phone per se, it's staying in the system, and then that system through HIPAA-Bridge is itself secure. So that's what I wanted to clarify, that it's a little bit different than just sitting on your phone per se. And indeed, some people believe that it needs to be there for audit trail and record keeping, so it's kind of a gray area.
Yeah, I'll just add that, you know, this is a separate app on your phone. It's not like iMessage where it's just in there with all your other regular messages. This is a separate app that's walled off from the rest of your phone, and anything you do within this app remains HIPAA compliant and on our servers and on your own if you choose to host it on site. But because it's a separate app, anything you do within that app is protected and encrypted. In fact, it's military-grade triple encryption.
That's exactly right, Raina. So it's the platform that's protected per se, right? Rather than, like you just said, it's not sitting on your regular messaging. Yeah.
Exactly.
And that would have been all that we would have added from the Everbridge team is the military encryption, and that if it's sitting in a separate app, that is what creates the HIPAA secure environment. So we are going to move on to another question. If my smartphone can easily accommodate a face-to-face visit, it appears I can also provide you with my heart rate, pulse, blood pressure, etc. via the many devices and intelligent sensors now appearing on the market. How do you see this impacting patient care and the number of patients you can service each day? Great question.
Well, I think that it really, the more information we have, the more accurate the visit becomes. So I think all of these, all the things that are now integrated into mobile phones and wearable mobile devices, only add to our care. I don't know if it'll affect in any way the number of patients we can see or the number of visits. I don't think it will have any material impact on that unless if one of you other panelists has any insight into that, please add it. But I think more information the better, but I don't think it'll affect the number of patients we can see or increase or decrease that number.
This is Keith Algozzine. I would say that it's more the broader scope of application. So again, we really like to say that it's again the appropriate level of care that is delivered. So if you have pink eye, it's my personal opinion, but I would argue that conjunctivitis case is more efficient without your heart rate and your blood pressure and all those other things that bog down and just put layers between patients and providers and cost. But where what you're talking about is very helpful is if you're trying to move into the realm of taking care of either more acute patients or chronically ill patients, and you're trying to your goals are now to reduce readmissions or reduce nursing home transports, and all those things become critically important in order to make an accurate diagnosis and or triage.
It's a great point, and the other great point about telemedicine and pink eye is that you don't expose yourself to it.
Right.
No way it can be transmitted to you or your...
Very good point.
Well,
Dr. no, stay at home.
Yeah, I mean, when we see it, we have to wipe down the room. I mean, it's really a big deal. It's very highly contagious. So telemedicine is the way to go for that diagnosis.
Good to know. This is Lisa again with another question. As a cancer center, we get requests for second opinions from patients out of state. Our physicians are not licensed in that state, so how do we bill that?
So this is Rahul. Yeah, Raina, you go. If you have the answer, go, because I was going to bounce it back.
I have one answer. I'm sure there are many, though. So you can still do a consult across state lines. It's where the prescribing comes in where it gets a little bit shady, and that depends on the rules of the state. So if I just, one of the things that we do with Everbridge is set up second opinion consults just like this. And one of the places I'm doing it is at Wills Eye Hospital, which is one of the top eye hospitals in the country. And their oncology group, the ocular oncology group, gets consults from all over the world. From patients, who want to fly in for a quick consult, but really all those doctors need is a copy of their CT scan or their last PET scan, and some reports, and that's it, and they can make a very good diagnosis. So again, I'll reiterate that you can do a consult across state lines. It's just when you're prescribing medications that the laws of the state apply.
We're going to move on to our last question. The Joint Committee reversal specified safe, secure texting of orders. What about texting clinical advice that does not specifically involve a physician order?
Can you repeat the question one more time?
Yep. The Joint Committee reversal specified safe, secure texting of orders. What about texting other clinical advice that does not specifically involve a physician order?
It was very interesting. This is Rahul. It was very interesting that they specifically went after orders. And I think we don't know what they were thinking. We can perhaps pose it through Everbridge as a query to the Joint Commission for clarification, and maybe that's something we can work with Everbridge to accomplish. But what they did, I believe, is they took the highest road or the thing that needs the highest integrity or fidelity, and that's an order. So if you can text orders, potentially you could do everything else because the order is sacrosanct. That's the thing you have to protect. Do you agree, Ranya, with that?
Yeah, absolutely. That was very well said. It's just like our stroke trial. We went with the most complicated patients, and worked backwards from there. So it's exactly what you said. If you can text orders, you can text anything.
Yep. And this is Lisa again. I would also add that we have actually been speaking with the Joint Commission for the last couple of weeks, and that they are planning on coming out with a new statement over the summer that's going to give more details about this. So I think this is, your answer might be more complete in the summer when the Joint Commission comes out with its next statement. So, okay, so at this point, we're going to wrap up our event. Thank you to all of our panelists for a great session. Thank you so much, everyone. And thank you to our attendees. If you did miss any part of this webinar, we will be sending out an email with a recording in a few days, and we'll be sending along the slide deck as well. If you haven't already, please take a moment to follow us on Twitter at Everbridge. You can also check out HIPAAbridge.com for more information on our clinical communication and care team collaboration application. Thank you all again for your participation in today's webinar. We hope to see you soon at our next clinical discussion. Thank you.